Welcome to Yes, You Can Perform a Fear-Free Canine Orthopedic Exam with Dr. Kristen Kirkby-Shaw. I'm Christy Keith, Senior Communications Strategist for Fear-Free. We'd like to thank our friends and Fear-Free sponsors at Zoetis Pet Care for making this webinar possible. It's my pleasure to introduce our presenter. Dr. Kristen Kirkby-Shaw is an accomplished and highly skilled double board certified veterinary surgeon who has done extensive research in soft tissue surgery and rehabilitation. She has published numerous journal articles and textbook chapters, received several awards, and has spoken at national and international conferences. She received her DVM from the University of Florida in 2003 and also did a 4-year small animal surgical residency there, becoming a diplomate of the American College of Veterinary Surgeons in 2008. In 2010, she moved to Seattle and began working in private practice. She became board certified in veterinary sports medicine and rehabilitation in 2013. And of course, she is a fear-free certified professional. Thank you so much for giving your time to us this evening, Dr. Shaw. Please take it away.
Thank you so much, Christy. And I just want to echo what you said. Thank you to everyone out there for taking the time to join us tonight. I know how hard it is to rally at the end of the day, at the end of a long week. So I hope that you're sitting down with a nice beverage that might help decrease any stress or anxiety that you may have had in the clinic today. So I know when I attend presentations, I kind of categorize a talk into generally one of two buckets. And the first one is what I call confidence booster. And that's when I go to a presentation and the speaker is talking about something that I already do in practice, but it makes me think, well, cool, I'm glad I'm not alone in this and I'm doing it the right way. Or good, I'm glad I had the right dose of a medication. The next category is one that is, I would consider kind of pearls and nuggets. And this is where you walk away from the presentation with immediately tips or tricks or tools that you can use in practice. Obviously, there's going to be some presentations that don't fit into either category. But before we get into the real details of this presentation, I want to share a quick story with you about how I ended up where I am in my career. And so it started when I was a senior in vet school. I knew I wanted to specialize in something, but I hadn't quite committed to surgery. But then I had my orthopedic surgery rotation and I fell in love. I absolutely loved orthopedic surgery. And then someone on that orthopedic rotation said that women weren't any good at orthopedic surgery. So that was just the kind of nail in the coffin last straw that I needed to fully commit myself to becoming an orthopedic surgeon. So I was very lucky to land a great residency with a very strong ortho focus. And one of my jobs as a surgical resident was to teach the vet students the orthopedic exam. So every other week, my dog Bailey, who is pictured here, would come to work with me and he would teach the students how to do their orthopedic exam. And he was an absolute angel. This picture here was actually staged to demonstrate me doing passive range of motion. That's why he's on the floor and I'm on the floor. But when we would do the orthopedic exam, we would plop Bailey up on a table. He would lay there just like this and let the students palpate. Now, looking back, I think he was probably doing an awful lot of lip licking and yawning that I didn't notice or I didn't think much of at the time. So one day, I'm a first-year resident and I have a case that I've got to do my own orthopedic exam on for a dog that comes in with a thoracic limb lameness. We bring the dog to the back to the treatment area, plop the dog on the table in the middle of the treatment room. Dog's restrained by a technician and one of the students. And I go through my very thorough, very systematic orthopedic exam. And at the end, I have not made the dog cry out. The dog has not pulled back and I have no idea what's wrong with the dog. So I asked my attending clinician for a second opinion. He goes through and does his orthopedic exam and lo and behold, the dog yelps. And so the lesson that I was taught that day was that I wasn't pushing hard enough. So this particular dog didn't need orthopedic surgery. So we sent him home with recommendations for rest and Rimadyl. And this case just left me feeling all kinds of wrong. And it was actually one of the catalysts for me pursuing rehab because I knew that I wanted to be able to offer something more than orthopedic surgery. So over the last 15 years or so, my orthopedic exam has evolved tremendously, and it looks nothing like what I was trained to do or what I used to teach students to do. And a lot of it came from pearls and nuggets that I picked up from human physical therapists and other rehab vets in my training and along the way. And then it was last year when I was actually going through fear-free certification. And at the end of the course, I felt so validated, and I felt like my confidence was boosted because it turned out that the orthopedic exam I had evolved into doing was actually on the right track. So my hope, my goal for you guys tonight is that your confidence is boosted and that you leave here with some pearls and nuggets and tips and tricks to get you, again, feeling more confident in your orthopedic exam as early as tomorrow. So we're going to go through a brief overview of kind of what the orthopedic exam is and why. Touch on some of the fear-free principles. And I know many of you guys out there are fear-free certified. If you're not, I highly recommend it. But we'll talk about the ones that I think are most important as they apply to the ortho exam. And then I'll talk you through what I have developed into my version of the orthopedic exam, which I do think is pretty close to fear-free. All right, so who needs an orthopedic exam? Really, obviously, if a dog presents to you for a mobility concern, for a lameness, for limping, you're going to want to do an orthopedic exam. But we know that there's a lot of dogs that may have underlying orthopedic disease, and they don't present with an obvious lameness. So you may want to incorporate an orthopedic screening exam, and I'm going to show that to you later on. You'll want to incorporate that into a variety of cases, especially dogs that are at risk for orthopedic disease such as OA. So those that are overweight or obese, if they have any history of joint surgery or joint injury, our canine working dogs or athletes, and then certain breeds that are at risk. So your Labradors, your German Shepherds, Golden Retrievers. I do want to say that most of this presentation, I'm going to say dogs, and we're going to focus on dogs, but many of the things that many of the principles we can apply to cats, but the majority of this presentation is kind of tailored towards the canine exam. So as I mentioned, a fear-free ortho exam is not what you learned in vet school, especially if I was the one teaching it to you. We've moved beyond that, so we're doing things a little bit differently now. And the goal is not to make the dog painful. Actually, what we're trying to do is find the most subtle signs of discomfort, but not causing pain. We're looking for compensation and movement and avoidance of certain activities that may indicate that the dog is uncomfortable. But we aren't trying to purposely cause that pain. In my opinion, and in my experience, you can observe or you can learn so much from observation, almost more than you can from the actual palpation part. And we're going to talk a lot more about that as we get into this. Absolutely avoid stainless steel tables. If the exam has to be done on a table, cover it with a yoga mat, cover it with blankets. Don't do like we used to do, just plop them and restrain a dog on a stainless steel table. The last thing I would point out is I strongly recommend against using your white lab coat. So dogs do get afraid of that. And so I don't wear a white lab coat at all for any sort of exam anymore. I generally have a fleece on that has treats in the pocket. So I would definitely avoid using anything that's going to tip the dog off that you're a doctor, unfortunately. All right, so when we talk about a comprehensive orthopedic exam, this is like your thorough, gotta figure out what's wrong. This is not going to be part of an annual visit. This is not something that I recommend working into a 15-minute exam. You're just not going to get as much out of it as you really could if you plan ahead. What I do recommend is incorporating what I call a 1-minute orthopedic screening exam, and that can be incorporated into any type of physical exam. When I see a patient for a soft tissue condition, if I'm seeing them for a mast cell tumor or something unrelated to orthopedics, I will still always incorporate this 1-minute screening in. Then when it comes time to really needing to dive deeper into this thorough orthopedic exam, you can do it, I call it orthopedic workup. And many times this is actually a drop-off appointment But even if it's a full-fledged just in and out appointment, you want to plan ahead for this. You want to plan plenty of time, plenty of resources, and planning ahead from a pharmaceutical standpoint. So for me, if a dog is already on pain medications and NSAIDs, something that is, being purposely prescribed to treat and manage pain, I much prefer that they are given that medication that morning or the evening before they come in. Because I don't want them to be in a lot of pain, because I think there's this misconception that you need them to be in pain to show the lameness. And my hope is that you can pick up on things that are more subtle than that. If they have unmanaged pain, their fear, anxiety, and stress is going to be so much higher. So my opinion, give the pain meds, use trazodone. So it's going to be an incredibly rare dog that wouldn't benefit from pre-exam trazodone for a full orthopedic exam. It just makes it easier for everyone. Then ideally no food. And so I know this kind of contradicts give NSAIDs, but don't give food. It's going to depend on which NSAID you're using and what kind of time frame whether it's once a day or BID dosing. But the point of no food is that if they come in and they're hungry, they're going to like you and your treats more. And you're going to be able to build that bond with them initially and get them to do things for you. Obviously, there's certain dogs that you can feed them breakfast and they're still going to be hungry. But the other thing is, if you're planning ahead, you may have them drop off for this orthopedic workup that may include further diagnostics, and you may want to sedate them further. So I like them to come in with a fairly empty stomach. That allows me to give treats as needed and then sedate further for diagnostics if needed. So why would you bother an ortho exam if you're not a surgeon? I think hopefully if you're interested in this topic and you're here listening to this tonight or on a recorded version, it means that you kind of you get the answer to this question. But really the reality is that many, if not most, of the causes of lameness don't actually need a surgeon or don't need surgery. The most common causes are going to be related to OA. But if you do need to refer, then it is helpful for the client and the whoever you're referring to have an idea of what may be going on. And obviously doing an orthopedic exam is going to help guide your diagnostic imaging. So these fear-free principles, again, this is just a couple slides to go into this. I think if you want all of the details of fear-free principles.
Your audio is coming and going a little bit. Are you moving closer and further from your microphone, or?
I will do my best to not do that.
Okay.
Can you hear me okay?
Sounds really great now, but sometimes I think maybe you're leaning back and it becomes a little hard to hear you. Okay.
Thank you. Sorry about that.
No problem. Thank you.
All right. So fear-free principles, again, we want to get off on the right foot with the dog. And that starts by creating the best environment for them. So we want a clean exam room, clean meaning free from odors as well as visible hair and soiling. Rugs. So, oh my gosh, if there's one thing that you can do to change your practice in your exam room is to put down rugs wherever the dogs are going to be walking. You've probably seen those dogs that get terrified of slick floors. So please put down rugs anywhere you expect a dog to walk. Toys, beds, staff, lavender, all sorts of things that you can do in the exam room to make it a more comforting environment for them. Obviously, use a calm voice. This is something I still have to work on myself, not using that high-pitched voice. Dogs actually get more anxious if we're talking really high versus just a nice, calm, low voice. And then the one that I think a lot of people have a hard time letting go of is doing a TPR first. So if your technician goes in and does a TPR, and then you come in and expect to do an orthopedic exam around their back end, it's going to be so much harder. So I find that even when I pull out my stethoscope, I still do TPRs, but I don't do them until the very end. If I pull out my stethoscope, the dog correlates that with the temperature, with the thermometer, and I've kind of lost trust right there. So don't start the whole exam with a TPR. And then pre-exam pharma, I am a huge proponent of this. Working in a referral practice, I'm fortunate that we can flip through medical records and have an idea of whether this dog has a history of fear, anxiety, or stress, and my technicians can call ahead of time and talk to that client and make sure that they have trazodone at home, they have GABA at home, to make sure that they're giving it before they come in. And I have, in some cases, if there's not a referring vet that is in the picture to be able to prescribe that, and we know that the dog's going to be anxious. I've had clients that actually call ahead and they're worried about the stress of coming in. I'll do a telehealth, a virtual kind of meet the client, meet the pet virtually. And I think this day and age, it's much easier and more accepted to do this and establish this client-patient relationship, and then be able to prescribe a medication before they come in. So not going to get into any more details than that, other than use the pharma, especially if dogs have a history of stress and anxiety. All right, then lots and lots and lots of positive reinforcement. These are some of my favorite treats that we'll use in the exam. And then last but certainly not least is looking for signs of stress and understanding what this patient's baseline is. So if they're already stressed and they're already showing some of these lip licking, yawning, things like that, these are signs that also can be mistaken for pain. And so we need to know what we're starting with in order to know what early signs of pain may be versus just stress. And so this is actually Bailey, demonstrating. This is actually the 1 minute orthopedic screen that I'll show you a little bit more detail of later. But at the time of me taking this video, I honestly didn't appreciate that he hated it. He was being a perfect angel, but as you can see, he's pretty stressed out. He's not even laying down on a stainless steel table. I'm the one doing the palpation, and you can see he's already stressed. So, and those weren't, I don't think, signs of pain. So when I went through the fear-free training, I think this was a concept that really made me feel the most confident and the most validated that I was okay in what I was doing, because it's the principle of wants versus needs. We, of course, want to do a very thorough, we want to do a very systematic orthopedic exam. Yeah, it's best, certainly it's best for my body, and it's easiest if the dog is on a table in lateral recumbency, being restrained. That is all ideal. But the reality is it's uncommon that we get all of that. What we actually need is trust from the patient. We need them to be relaxed. And then we need to just narrow down the problem in order for us to get to the next step. Sometimes we're able to do all of the things. Sometimes the dog just wants to lay on the floor and they will let us do a completely thorough and systematic exam. Sometimes the dog is happy standing and allows us to do a completely thorough and systematic exam. Sometimes on the other end of the spectrum, we literally don't get to touch the patient the first time we see them. And we just start by establishing that trust and establishing just somewhat of a rapport to build on for future visits. And I'll explain this to clients. And I think as we have these conversations, I've never had somebody push back and say, oh, actually, I want you to make my dog stressed or anxious. I'll say, you know what? This is all we're going to do today. I'm just going to watch your dog. I'm going to give your dog treats, and we're going to have to schedule another appointment. And then probably sending home some pharmaceuticals. So again, balancing these wants versus needs. Please don't feel bad about not doing a thorough systematic exam. If you're doing all of these other things right, it's okay. And this is the thing that made me feel so much better, is it's okay if you don't do absolutely everything the first time. All right, so how do we do this fear-free orthopedic exam? So in my opinion, 80% is observation, 20% is palpation. So when I was a vet student, again, I remember starting an equine rotation. It was actually equine surgery. And I'm not a horse person. I didn't grow up with horses. And the first day, the orthopedic surgery resident on equine said, I want each one of you students to name 10 things wrong with this horse just by looking at it. I couldn't even tell you what color the horse was beyond just brown. And it, like, to me, just being able to look at a horse and know what was wrong, there was nothing I could do. At the beginning of the rotation, I would say. But this example, I think, is, now when I think about that with a dog, yeah, I could easily just look at a dog without putting my hands on it and tell you 10 things about it. And so I think just honing in on our observation skills and then putting our hands on the patient, this is, to me, kind of the essence of what makes it fear-free. So we'll go through all of these. Again, home videos fall into the observation part. We'll talk more about that. So this is my 1-minute orthopedic screen. So it starts with observing movement and posture and transitions. I'm going to show you examples of all of those. And then moving into paraspinal palpation. So yes, that is a palpation skill, but what you're doing is just looking for a change in the paraspinal muscles. We're going to do a 3-leg stand. And so yes, that's putting your hands on it, but you're observing for how much weight the dog's putting through your hand. And I'll talk through a little bit more detail coming up. Joint swelling and then muscle atrophy. These are the kind of only things that are really true palpation that you need to deeply feel. And all of this is done with the dog standing. So you don't have to do any of this in lateral recumbency. In fact, none of it should be done in lateral recumbency. So it makes it very, very easy to incorporate into any sort of exam. All right, so starting with movement, ideally, you would be able to watch the dog move from a down position where they are relaxed with their person in the waiting room and watch them move into your exam room. Even pre-COVID, most of the time that didn't happen, right? So most of the time your technician would have brought the dog into the exam room, dog's already in the exam room, and you come in. Nowadays with COVID, the dog's in the hospital without their person, and they're already more anxious. Some of you guys out there may not be doing curbside anymore, and so everything is changed, right? But the point being, if you can watch the dog move from a comfortable, relaxed position to a stand position and into the exam room, you can see literally how did they stand, how did they move around. The other part of the movement component is asking clients to provide home videos. Now, if you ask clients to start showing you videos, you're going to definitely blow that 1 minute pretty quickly looking at home videos. But when we get into the more comprehensive exam, looking at home videos, how the animal moves around their home environment can be incredibly, incredibly helpful. The next one is posture. And each one of these dogs is, you can learn a lot just by looking at that posture. So the dog in the upper left, so the shepherd mix, you can tell that there's obviously some pelvic limb weakness. There's probably some neurologic component to this. She's also really tucked up in her shoulders. That's a compensation from having that pelvic limb lameness or pelvic limb weakness. The golden retriever in the middle was a 12-year-old golden retriever that presented with an acute onset of this right thoracic limb lameness. So you can obviously see that the dog is standing non-weight bearing. And it was sent to me with a diagnosis of elbow dysplasia, elbow arthritis. It's pretty uncommon for a dog with a long history of elbow arthritis to have an acute non-weight bearing lameness, especially in a 12-year-old golden retriever. So seeing just this sort of posture should make your hackles go up. In a dog of this signalment, this dog had a nerve root tumor. The dog in the upper right-hand corner, just looking at the tarsus from the cranial aspect, you can see that thickening on the medial aspect of the tarsus. So that's a diagnosis that, you can, with a lot of certainty, make from across the room. This is a 1-year-old Labrador. And that's going to be OCD of the tarsus. The Frenchie presented for suspected cruciate rupture, but you can watch the Frenchie stand and has a CP deficit, so that turns out to be more of a neurologic condition. And then finally, the black lab in the bottom right corner, that's our classic stance for a cruciate tear. So all these things that you can not necessarily come up with a diagnosis, but these things that you can learn just by looking at the dog's posture. Then we want to observe how they sit. And ideally, we're going to watch how they sit on their own, not as a command of us asking them to sit. So the Rottweiler on the left, this is about a 11-month-old or so Rottweiler that presented with concern for thoracic limb lameness. Didn't show much of a lameness on gait evaluation, but when she sat, she would kind of do this external rotation of her left thoracic limb. And we do see that frequently with dogs that have medial cordanoid disease or medial compartment disease. They will sometimes look like they actually have an external rotation or an angular limb deformity, but it turns out to be just they're offloading that elbow and putting it in a position that's more comfortable for them. The Frenchie in the middle is actually my French Bulldog, Beans. She's 14 and she has some significant neurologic deficits, and she obviously does not sit properly. So that's not normal. And then the Black Lab on the right is also my dog, and that's not a normal sit either, but he's just fine. He taught me that there is such thing as a sloppy sitter. So I used to have clients that when I'd ask if their dog was sitting normally, if that was normal for how they sat, if they were kind of kick their leg off to the side, they'd say, oh, they've always been a sloppy sitter. And I honestly didn't believe in sloppy sitters until I had one of my own. So just kind of noting that position and what's normal. So with transitions, this is now, we've watched how the dog sits, but we want to see how they move from that sit to stand or from a stand to sit. And this picture here, this is our classic positive sit test, or what some clients would describe as a sloppy sit. And this is, I wouldn't go so far as to say pathognomonic, but it is highly suggestive of a cruciate injury, because when dogs fully flex that stifle, the effusion, the joint effusion that's typically present with a cruciate rupture, that joint effusion is pushed into the joint capsule just by nature of flexing, fully flexing. By pushing into the joint capsule is where the nerve endings are. So it distends the joint capsule and it's painful for them. So they assume this posture of a neutral position of their stifle because it's more comfortable for them. Then when they go from a seated to a standing position, they tend to just use that one leg to the down leg, in this case it would be the right pelvic limb, to stand, and they don't use that the injured leg to thrust or push from a sitting position. Then we can also look at from a down to a stand or stand to a down. And I'm going to show you this golden retriever, and I want you to pay particular attention to his right front leg. This is a dog that has mild elbow dysplasia, so I don't mean to trick you because it's mild, but when he goes to push off from a down to a stand, he doesn't tend to put as much weight on that right front leg when he pushes off. So we can watch this a couple times. One thing, so he doesn't shuffle down, which is much more common with older dogs, but when he goes to push off, he pushes primarily through that left front leg. Let me show it one more time. So it is, again, that's a pretty subtle one, but if you start watching and you start looking for things like this and incorporating these transitions into your physical exam, I promise you, you'll start picking up on things and saying, so this is, again, it's not going to be pathognomonic for elbow, but it's highly suggestive, because if the dog is uncomfortable in their elbow or their shoulder, they may want to offload and push off more with the opposite leg. All right, and then now it's finally time to put your hands on the dog. So this is going to be the end of our 1-minute screening exam. The next part is the paraspinal palpation. That's where you take kind of your thumbs and palpate just along the epaxial muscles, not necessarily on the dorsal spinous processes, but just to the lateral aspect along the paraspinal muscles. And what you're looking for are muscle spasms. These muscle spasms are not the same as your cutaneous trunci. You're going a little bit deeper than that. And so what I find is that dogs that have pelvic limb issues, any of them. Any reason to hurt in the back end and to offload towards the front, they will start having some discomfort and pain and compensatory issues in their paraspinal muscles, and you'll see that as kind of trigger points or spasms. The other time that this can happen, though, is dogs that have shoulder injuries may be also compensating. Their latissimus dorsi runs all along that paraspinal pathway too, and so there may be some tension there. The 3-leg stand, actually I should preface this by saying that I have a video that goes through how to do this 1-minute screen, and actually, Christy, if you don't mind throwing that URL up in the chat. This is something that is housed on the Fear Free website, and you guys can go take a look at on your own time. So I'm not going to take the time to show you a video of me doing an exam, but it is a resource for you to use after this, and it will go through each one of these in detail. But so the 3-leg stand, this is with the dog standing. You're going to pick up 1 leg at a time. And what you're looking for is the willingness for them to pick up that leg. So for example, I had a golden retriever come in that had an FHO done a few years earlier, and on the left side. So left FHO, I go to pick up the left pelvic limb, no problem at all. Dog's happy for me to pick up the left pelvic limb. And by pick up, I mean dog's standing on all fours, and I just pick up that back left leg, no problem at all. Then I go to pick up the back right leg. Dog does not want to give me that leg and does not want to bear weight on the left pelvic limb because he's weaker there. So that's just a cursory way to figure out the strength and which leg the dog's more willing to stand on. Next is joint effusion or swelling in the joint. You're going to it's going to be much easier to feel joint swelling with the dog standing, actually. So that gravity and the force of their body is going to be more likely to allow the joint fluid to push out into the joint capsule and for you to feel that. And it's really nice to be able to compare one side to the other. You're not going to feel joint swelling or joint effusion in the shoulder or the hip. You may or may not feel it in the elbow. If you are, you're going to feel it on the lateral aspect, just underneath the anconeus muscle. The carpus, you'll feel it usually on the dorsal aspect. Stifle, that's the big joint that we're often feeling for effusion for. So always, just get in the habit of feeling for that on the stifle. And then the tarsus, you may also feel some joint swelling or that firm periarticular swelling. And then the last part, again, this is still screening, but you're looking for muscle symmetry or muscle atrophy and running your hands along, the spine, along both sides of the shoulder, both sides of the hip and the gluteals and down the hamstrings, and just looking for any asymmetry. So it's actually been shown that subjective palpation of the thigh muscles, so just with your hands, if you subjectively think that one side is more atrophied compared to the other, this has actually been shown to be fairly sensitive to say there's something wrong in the stifle. It's not specific, but it's pretty sensitive to saying that there's some stifle injury going on. So, and this is the link to that 1-minute screening exam, so check that out when you get the chance. And then moving on to the comprehensive orthopedic exam. So this is again the one that you want to schedule plenty of time for. I admit I've been spoiled in my position. I have an hour and a half for an initial examination, which I know most people don't. But if you're doing a true, thorough, comprehensive orthopedic exam, the best thing you can do is have the patient drop off for the day, have those pre-meds on board, and then be ready to move into any diagnostic imaging if you find a reason to do so. Use drugs. I mean, that's a pretty big tenet of Fear Free. So yeah, use the drugs appropriately, and this comprehensive exam is going to build upon what we just talked about with the screening exam. Starting with the gait evaluation, and I think the gait analysis is often where, at least when I was teaching students, this is kind of where I lose them, and people are like, oh, I'm gonna do gait evaluation. Yeah, a gait evaluation is important for a comprehensive and thorough orthopedic exam, but there's right ways to do it, and there's definitely wrong ways to do it. So, and by wrong ways, it means it's going to be counterproductive, if not pointless. No slick floors. You want to do the gait evaluation ideally outside with no distractions. That's kind of like, yeah, right, that doesn't really exist. So if that doesn't work, then inside on rugs, just not slick floors. You want to avoid distractions, so any smells, any sounds, owners, anything that's going to kind of tip the dog off to not just walk perfectly straight. And then but the next thing is just walking perfectly straight. So most dogs are not going to just walk perfectly straight on a loose lead. They're going to have some sort of shoulder harness on or a halter. They're going to be pulling. So that's really, really tough. In a perfect scenario, you'd actually watch the dog walk around without a leash in an enclosed area. So if you have that as an option, that's great. And for me, so I live in Seattle. So a lot of times during the winter, the weather is not super cooperative to go outside and do a gait evaluation. So we'll wind up either doing it in a hallway, or honestly, I'll just watch them walk around the exam room. But now we're talking about specifically your gait evaluation. This is what I mean by not helpful. So slick floors, dog knows where the door is that he came in. So he's going to pull for it, completely distracted, pulling. There's nothing that you can glean from this gait evaluation. So don't even bother with that. So some tips to help make it more successful. When you're watching, you want to watch from the back and from the side. Ideally, you're watching the dog walk and trot plus or minus run. You usually don't need to get to that. Usually just kind of the walk and trot. Watch those transitions between like a walk and a trot pretty closely, because sometimes that's where you'll catch like the hop or the skip or something that's a little bit off. Sometimes it's helpful to do stairs or circles. This is the part, but just don't get super hung up on, you know, having to do stairs and circles. I don't have stairs in my practice, so we don't do those. What I would say is, this is, if you're finding you're needing to get to these sorts of things, ask the client to provide home videos, because you're going to get so much more information from that, especially if you can use slow motion home videos. All right, so when we're trying to evaluate the gait, when we're looking for a thoracic limb lameness, we want the dog walking towards us, and we're looking for that quote unquote down on the sound. So that's dogs putting more weight on the good leg, trying to offload the bad leg. If there's bilateral issues, then we're going to see that a little bit more looking from the side, and it's going to look a little bit more like short strided. So here's an example, watching the dog walk towards us. So this is pretty good, walking on a nice loose leash, no distractions outside. You may have noticed that there is a right thoracic limb lameness. So that was a pretty good video, but I think most people would agree this is even better. So just doing a slow motion video, you can see down on the sound. So the head goes down when the left thoracic limb is planted. That's because her right front leg hurts. Actually, both of her front legs hurt, but her right front leg hurt her more. So she's trying to get her weight off of it as quickly as possible. So weight goes down on the sound leg. All right, it's still even better yet. So we brought her, this is all in the same day, brought Carly back into a treatment area, and we can watch her walk around on her own. In this case, you can see she's pretty uncomfortable on both legs. She's just kind of that short strided gait. She's also lame on her back right leg too. You might notice that, but she walks, and then when she stops, she kind of offloads that right front leg. And then last but not least, this is a home video, and this was what she came in for. Down there. So this is what she came in for: stiffness when getting up. So really obvious there, right? So you can see how she stutters and how uncomfortable that looks. So this is quite helpful to have this video provided by the client. The other nice thing about home videos is that it gives you a baseline, and then if you're going to institute any sort of treatment, you can be able to look back and see where you came from. I'm not going to not talking too much about cats, but cats is absolutely like so important to get home videos because they just don't walk around the exam room, right? You're not going to do a gait evaluation with a cat. So being able to see home videos for cats are really, really nice. All right, the pelvic limb analysis, the same idea. The dog's trying to offload the hurting leg as quickly as possible, but what we call it is a hip hike. So the leg that is less affected, they're going to put more weight on. And so they're trying to take their weight off of the hurting leg. So let's say the dog's walking away from us, the right pelvic limb is sore, it's lame. They're going to shift their weight to the left pelvic limb. That right hip tends to look like it's going more dorsal. More often with pelvic limb, but we're going to want to distinguish between ataxia and lameness. So this is a dog that presented. She does actually have bilateral hip dysplasia, but you can see with the left pelvic limb, it's pretty short-strided, and that left hip went up. Okay, and then also watching from the side, this is a dog with a cruciate injury, trying to minimize the amount of time spent on that leg, the leg that hurts. And then lastly, the value of slow motion, certainly here, you can kind of see a skip there, but we watch, this is Romeo, see a little kind of skip there. That's just more of kind of a transition between gaits, but then held his leg up through one transition, hold it up again. So for the sake of time, I'm not going to show you all of his slow motion video, but it is much easier to see his patelloluxation skipping gait with a slow-mo video. All right, moving on to the palpation part. So this is now the kind of the classic part of an orthopedic exam, where we're really starting to try and put our hands on there and sense something with our fingertips. When it comes to joints, what we're trying to do is we're trying to feel for heat. So heat is an indication of inflammation. So you may feel some heat in a joint. More often, we're going to be trying to feel for effusion. And again, effusion is going to be more easily felt with dogs standing. Wanting to feel range of motion. And so with range of motion, we're looking for reduced range of motion. Usually there's crepitus, or often there's crepitus that goes along with that. Or there's just reluctance to let you fully go through that range of motion due to pain. And then we will have some special tests. We're identifying either hypermobility or hypomobility. Hypo with an O, that is basically a reduced range of motion. Hypermobility means there's laxity in the joint. And so the most obvious example is going to be a cruciate tear, a complete cruciate tear. Then moving on to bones, we are wanting to palpate all along the length of the bone whenever we can. And then of course, there's going to be times where you want to pay particular attention to certain areas that may be of extra concern. For example, a thoracic limb lameness in an 8-year-old Rottweiler. You're going to want to for sure make sure you're palpating the distal radius and the proximal humerus. Of course, most common areas for osteosarcoma. Dog has a history of a stifle surgery. You're going to want to palpate over that implant on the proximal medial aspect of the tibia. And then, palpating for instability. If there's a fracture, then, that's not always, but often pretty obvious, and you're generally going to move straight to diagnostic imaging there. So moving from distal to proximal, usually palpating along the length of the bones and then getting to the joints, feeling for heat, effusion, range of motion, and mobility. Then there's the soft tissues, and this is the part that isn't, or at least not historically, isn't taught in great detail in vet school, or to most people. This is, for me, what I learned in going through rehab training, and this is where human physical therapists are very, very, very attuned and very trained at feeling very subtle changes in the soft tissues, such as muscle spasms and trigger points and pain. And there are courses you can go through. You can go through rehab courses, you can go through trigger point courses on learning some of these palpation skills. But there's some basic ones that I mentioned, like the paraspinal palpation, and then some other areas of soft tissue that are fairly common areas that will be a source of lameness. For example, the biceps tendon in the shoulder. Dogs that have elbow dysplasia, elbow arthritis, they are at a greater risk of having a shoulder tendinopathy as well, although we often see shoulder tendinopathies unrelated to the elbow. Knowing when it comes to soft tissues that the injuries are most likely to occur at the musculotendinous junction, then if you go back and review anatomy and understand where that musculotendinous junction is, first of all, and then what muscle you're dealing with, that can help you narrow down what the problem is. And then again, ligaments, cruciate's the most obvious one, but we'll also have our medial and lateral collateral ligaments and some other less obvious ligaments, especially when we get to the distal limbs, but not forgetting to palpate for those tissues as well. And then lastly, fascia, skin, scar tissue, not going to get into those details here, but knowing that these are areas that can be sources of pain. And if you're interested in going through more advanced learning, I encourage you to go through some rehab training, because this is some of the things that are taught there. Just want to kind of end with a few of the special tests that can ideally be worked into your comprehensive orthopedic exam. So starting with cruciate, palpation for cruciate disease. Cruciate disease is going to be the most common pelvic limb lameness that we're seeing. And the very first two signs that you will feel, or you'll see and feel, are effusion in the joint and pain with hyperextension of the knee, or pain with just putting in the stifle into extension. The reason for that is one of the jobs of the cranial cruciate ligament is to prevent overextension of the stifle. So if there's it doesn't even have to be partially torn, it can just be a sprain of the cruciate ligament. So it can be early disease of that cruciate. And you put the stifle into full extension, the dog may pull back. They may indicate that's uncomfortable for me. That is a protective mechanism. It's the body saying, my ligament here is not at full strength. Please don't go any further there. So if you can't do any other stifle palpation, just palpate for hyperextension. It's very uncommon to have a dog with a cruciate injury that doesn't have that is comfortable with full stifle extension. So if I see a dog that was sent to me for suspected cruciate injury, and they allow me to do that full stifle extension and they don't react to it at all, it makes me question what the diagnosis is. Of course, we're going to move on and do some other tests, but many times you won't have positive door or positive thrust, but you'll still have this pain on extension with a cruciate rupture, or cruciate injury, I should say. So then other things we're going to feel for: medial buttress, pelvic limb atrophy. So I mentioned that has been shown to be a sensitive indicator for cruciate disease. Cranial drawer, tibial thrust. Let's go through how to do that. So cranial drawer, you do need the dog to be fairly relaxed and cooperative. And it is ideal, it is certainly ideal to palpate, to palpate with a dog in lateral recumbency. It's easier to feel. But you can feel it with the dog standing, especially if they're not wanting to put much weight on that leg, especially if they're non-weight bearing. You can pretty easily manipulate to do a cranial drawer exam with that standing position. So the keys here are proper positioning of your fingers. And for the sake of time, I'm not going to go into all of these details here because I do have an exam or a video that goes through these details. But what I want to point out is where people often have problems. And that is, rather than having cranial caudal positioning of your fingers, they're more medial lateral. The other thing is squeezing too hard. So if you squeeze too hard as you try and push and manipulate, the dog's going to react painfully, and that can be a false positive, or they'll just kind of tense up and you're not able to do that manipulation. So you don't have to squeeze hard. It's often not a highly uncomfortable test for them, especially if it's a complete tear, ironically. If the dog is too stressed, if they're too anxious, if they're fearful, they're going to tense up their muscles, and it's going to be hard to feel for this. I mean, it happens to everyone. This is where you can, again, try it with the dog standing, or you may need to use, more sedation in order to palpate for that cranial drawer. But it's if you can put your hands on the dog, there's really, really high likelihood you can be able to test for that hyperextension. Tibial thrust. So I know that when I talk to vets, some people will have hard time with tibial thrust and easier time with cranial draw, and sometimes it's vice versa. They complement one another, right? So it is ideal to be able to do both of the tests. If you had to just pick one, I mean, tibial thrust is a little bit more mimicking what happens when the cruciate is torn, and it's certainly what we're trying to correct for when we do any of the surgical corrections. So ideally, being able to palpate for tibial thrust is great. And again, with the dog in lateral recumbency, it's easier, but you can do it with them standing. My biggest recommendation here, what I see people do incorrectly, is when you are pushing with your finger here to flex the tarsus, you do not want to be bending the stifle. So you need to keep that stifle in a neutral position and not bend it in order to allow that tibia to thrust your finger forward if it's going to. So let me show you a couple videos. So this dog, of course, is in surgery, getting ready to go to surgery, and it does have a complete cruciate tear. So the dog's asleep, and it's a very obvious one, but just showing that the positioning, so patella, fibella, tibial tuberosity, and fibular head, that's the positioning of the fingers. Now for a tibial thrust, you want to test with the dog's limb in neutral and with internal rotation of the tibia. And so you're running your finger down along the patellar tendon to end right on that tibial tuberosity, and that's with internal rotation. This is neutral. So internally rotating that tibia can make it become more dramatic because, again, one of the jobs of the cruciate is to prevent internal rotation. Patella luxation. So this, most people are usually pretty confident with this, but the trick here is making sure that the stifle is in not fully extended, but more closely to extension than flexion usually. And then internally or externally rotating the tibia as you nudge that patella with your thumb. Okay, yeah, for the sake, if anybody has specific questions about patella, I'll come back to it, but for sake of time, just keep going here. Because I do want to talk about ortolani, because this is one that I think I found that people don't feel comfortable with. And so ortolani is testing for hip laxity. And if the dog has hip laxity, if they have a positive ortolani, they have hip dysplasia. And it means they are likely to develop arthritis. It doesn't ever mean that they're going to be clinically affected. You've got to, you know, it's ideal to do more imaging at this point, but it is a great screening tool to do an ortolani exam for at-risk dogs young. So you can do this as early as 16 weeks of age. My Labrador, I did when he was 16 weeks of age. I brought him in, gave him exactly, actually, I just start with Torb, and many cases you can just get away with 0.2 mg per kg of Torb. This is one where you do want them on a table, but you're going to pre-medicate them first to make sure that they're comfortable. Tips here, you want to stabilize the sacrum, not the hip. So this proximal hand, my pinky is all the way down on the table, stabilizing the sacrum, not over the hip joint. So if your hand is too far lateral over the hip, you're not going to be able to stabilize that pelvis very well. The next one is your distal hand is around the stifle, and you're going to be pushing that femur towards your top hand. So you're going to be applying a proximal force here. Then you're going to adduct the limb to kind of bring the stifle towards the table to start as you're maintaining that proximal force. And then you're going to abduct. And what you're looking for or feeling for is a clunk right over the hip. So here's the actual video. So I'm pushing in, and then as I abduct, watching and feeling for a clunk. And so you're going to see it on this next one. Hopefully you saw that kind of clunking in there. And that is the hip, the femoral head was subluxated outside of the acetabulum. As you bring it up, it kind of clunks back in. That's a positive ortolan. So you want to palpate for this again in young dogs as early as 16 weeks of age. Once they become mature, I don't have a great age here because this dog was actually about 2.5, which was surprising for this to find a positive ortolani. But once they have really significant changes to that joint, meaning they have a lot of proliferation, osteophytes that develop around the joint, you don't get that nice clunk anymore. In fact, you may not get any sort of upward lining. So it is an exam that is best performed in that first year of life and as early as possible to identify dogs that have hip dysplasia. Biceps stretch test. So the biceps muscle is a fairly common cause of thoracic limb lameness, and it is often associated with dogs that have elbow dysplasia, elbow arthritis, because the biceps muscle originates on the scapula, crosses the shoulder joint, and then it inserts on the radius and ulna. So it crosses two joints, which immediately puts it at risk for being injured. So the way that we test for discomfort or pain is by stretching it. So putting it opposite of its full action, which is to flex the shoulder and extend the elbow, as shown here. And then you may need to come and put some additional palpation or pressure over the origin of the biceps tendon up at the shoulder. Dogs that have very severe biceps tendinopathy, you don't even have to apply this pressure. You try and put them in that stretch and they don't like it, they immediately pull back. Those were a little bit more mild. If you apply your pressure here with palpation, what you're looking for them to do is pull back. And if you find that, then that suggests that they may have a shoulder tendinopathy. All right, as I mentioned, there's a link for the full orthopedic exam, and this one it takes me about 20 minutes to do the demonstration. In real life, depending on the dog, I can do a comprehensive exam much quicker, a few minutes, again, very much depending on the dog. So I allow for about 20 minutes or so to do this exam, making sure that the dog is comfortable throughout it. So hopefully Christy will share this link for you guys and you can watch it on your free time. All right, so after you've done your exam, the next step is going to be diagnostic imaging. We're not going to get into that, but radiographs are always going to be the place to start, even though sometimes we may need to end up with more advanced imaging, but high quality, well-positioned radiographs, orthogonal views, use stress-free handling and sedation to get these. To wrap up, all right, the 5 keys to take away from here. So observation, just getting used to seeing how dogs normally move and their normal postures and positions. And then it'll help you pick up of what's abnormal. And again, it's not going to tell you all the time. Well, it's maybe sometimes going to guide you to exactly what's wrong, but it really starts giving you clues that you start to put together as you build your case for further diagnostics or for a complete diagnosis. Use home videos. So ask your clients to send you videos. Just really can't emphasize that enough. When you're doing any sort of palpation, you're looking for that earliest sign of avoidance or discomfort, and it often looks like signs of fear, signs of stress and anxiety, but you want to look for the most early signs. So it might be just dilation of the pupils or holding the breath. If you find that, that's a good clue that you're getting to an area that they don't like you to touch. You've got to make friends with the dog first, and you've got to earn their trust in order for them to really relax. And I promise you're going to feel so much more, and you're going to find those subtle signs so much easier if you're able to start with a relaxed dog. And that includes not starting with a TPR. That's not getting off on the right foot. Again, better exams through chemistry for sure. Use the drugs. It just helps everyone involved. Incorporate that 1-minute screen. So the more that you do this, the more you incorporate it into any exam that you're doing, the more you'll start to recognize what's normal, what's not, what's abnormal. And then lastly, and possibly most importantly, is don't sacrifice these fear-free principles just for the sake of being complete and thorough. That is what I was trained to do, and that's what I did in my early career, and I have all sorts of regret to this day. For putting dogs in stressful positions and causing anxiety when all I needed was just a little bit more patience. So with that, I'm happy. Well, so the first thing I'll point out is, again, I am an employee of Zoetis, and thank you to Zoetis for sponsoring this presentation. And we've got all sorts of cool resources for you, including videos for cat orthopedic exams by the one and only Dr. Duncan Lascelles that you can find linked through this website, The New Science of Pain OA. And yeah, so with that, Christy, I'm happy to take any questions.
Great. Thank you so much, Dr. Shaw. That was fantastic. And we have tons of questions. And I'll give you one guess what many of them are asking about.
The dose of trazodone and gabapentin?
Yes. We predicted this before it even started, that was going to be our number.
Yeah, so my dose of trazodone is usually 3 to 5 mg per kg, and gabapentin, it depends whether the dog's already on it or if they're fresh. So, but to be honest, I tend to go high on gabapentin when I'm going for any sort of sedation. But also, you know, if it's a more anxious, a more fearful dog, I'm going to go closer to the 30 mg per kg. If it's a geriatric dog or they've never seen gabapentin in their life, might go closer to the 5 mg per kg. But for me, I'm usually at least 10 mg per kg of gabapentin in these scenarios. So 300 to 600 milligrams for most dogs.
Would you say, and this is a question that we got a few variations on, that some people have noticed that trazodone either wasn't enough or didn't, or actually made the dog more reactive to certain things. Mm-hmm. Is combining it with GABA going to make that all work more smoothly? Is that your favorite recipe?
Yes, I do think that they are synergistic. So I think that absolutely there's cases where trazodone alone isn't enough, or you have to go higher on the dose. But I find when you combine it with that gabapentin, it's really nice. The other one that we started using more of, and this could open up a whole can of worms of conversation, and it will depend on where you live, but CBD, and we use Elevate Calm and Comfort. So it's just a higher dose of CBD, and that can be helpful as well in that cocktail. Now, there's going to be some dogs that's not enough. And once they get to the hospital, especially if they're aggressive, you know, and I would say that, aggressive is the wrong word. If they're incredibly fearful, mm-hmm. and that fear comes out as aggression, we are going to reach for dexmedetomidine usually as the next step, or sometimes butorphanol. Of course, it's going to depend on the individual patient, but I think the GABA trazodone combination is a great place to start.
And I'm glad you brought up CBD because we had some questions about that as well. So you're really just hitting on all the bases here. This was a question. This is what we in journalism call a loaded question, but we're going to go with it. How do you address the issue of ongoing / increased fearfulness or nervousness due to using food luring to perform exams and treatments?
Yeah, I think there's a lot of education that needs to go on in terms of educating the profession on luring itself and what that means. Because I think most people don't know that if you just lure an animal, it's going to make them more and more and more anxious. Mm-hmm. And honestly, I didn't recognize that until going through this course, until working with a vet who really had a very strong behavior background. So I think it's a matter of really continuing these discussions and continuing the fear-free discussion and teaching our colleagues that luring is bad, and how to do it appropriately. So, you know, giving the treats, not just like teasing them along the way. So I don't know if I answered the question, but I appreciate the question. I think it's a good one.
No, I think that a lot of pet owners also don't understand the difference. It's part of why they don't like what they perceive as so-called positive training, because they misunderstand the psychological mechanism that you're going for. And so I am neither a veterinarian nor a trainer, but as a dog owner, learning the difference to me was really just a moment that was my big aha moment in, you know, acclimating dogs to things or training them. Oh, that's great. So we're going to shift gears now to money, the second favorite topic after drugs in our profession. How do you charge for these visits? The same as a regular exam, or?
So I will say, I know that my situation is a little bit more unique, but we would charge for the original consultation, which includes the full, the initial exam. It includes a lot of discussion and a lot of talking to the client. So for me, again, it was an hour and a half, but an hour of that is spent talking to the client, and it's gathering the history, and it's the educational piece to the client on the back end of it. But if we need them to come back and drop off for an orthopedic workup, usually at that point, I don't charge for another exam. We would just charge for outpatient hospitalization, which in our practice is about $50. And that would include oral sedation, which we would usually send home with them.
Great. Have you noticed any correlation between hiccuping and pain being, do dogs hiccup from being in pain?
I have never noticed that.
Has observed this.
Huh.
Yeah.
I have not seen many dogs hiccup. I remember when my dog was young and he hiccuped a lot, I thought it was so cute because I just rarely saw dogs hiccup. That's a great observation. I would think that if the dog comes in and they're totally normal and hiccuping is not normal for them, and then they start hiccuping during the exam, I don't know, my gut would tell me that it's more an anxiety issue, but that it could be that they're anxious, that you're getting somewhere near a place that's painful for them.
Just answering someone's non-veterinary question here. There we go. Done. So how do you grade your patellar luxations?
Okay, yeah, let me go back to that. So patellar luxations are generally graded 1 to 4. This is one of the few areas that was pretty consistent, 1 to 4. I say that compared to like a lameness evaluation where people make up their own scoring systems. So grade 1 to me means that the patella is riding in the groove. When I manually luxate it, it will pop out, but as soon as I put the limb through range of motion, it's going to come right back in. A grade 2 is where it's riding in the groove most of the time. I can manually subluxate or luxate it, sorry. And it will stay out for a period of time, maybe a few flexion extension cycles, but then it's going to pop back in and prefer to stay in the groove. A grade 3 is where it's riding outside of the groove, but you can still manually replace it by kind of nudging it back in. And a grade 4 is where it's out and it's stuck out. And those grade 4s are often associated with much more significant limb deformity. That the grade 1, 2, and 3 are often, especially a 2 to a 3 can be a progression from a 2 to a 3. A grade 4, a lot of times those are dogs that are born with a pretty severe angular limb deformity. Hopefully that answers the question.
I can't imagine you doing it any better. When you go high on pre-visit meds, do you run the risk of blurring symptoms?
Yeah, of course, yes, and that is the risk. So this is where trying to balance the patient's history and their need for the meds. So if it's a dog that, if you're looking for something very, very subtle, then it becomes much, much trickier. But if you can combine home videos and looking for things ahead of time, and then looking for some of those more subtle changes, the short answer is yes, you do run that risk. But this is the balance between being able to maintain a long-term relationship with this patient and potentially build on your exam over subsequent visits, or getting everything you want at one visit.
Mhm.
So it's always a balance, but the short answer is yes, and trying to figure out what that sweet spot is.
Plus, there's a risk in the other direction too. So, yeah.
Yeah.
Great. Okay. We have 8 more questions. We're not going to be able to get to them all. It is already 12 minutes past the hour. Are you okay to go for a couple more?
Oh, I'm great. Yeah.
Okay. One veterinarian says that a current question she asks clients when asking about their pet's mobility is how the pet handles stairs, such as runs up them or how they go down the stairs. Is this a good question?
Great question. Yeah, absolutely great question. Because it can go even further of, do they sit at the bottom of the stairs and look up and think, oh, all right, I've got to do this, or at the top of the stairs? Because I had actually the black lab that I showed you the video, the gait evaluation video, she would not do stairs. She was incredibly reluctant to do stairs. And she was actually part of a clinical study we were doing for a medication that's not available yet. But when she was treated with this medication, that was the main feedback that the client gave us, that she was happy to do stairs. And so, yeah, I've observed it with my own dogs. So looking for stairs is a great one. That's a really good one to look for with cats too.
Great. And this is our last question. I'm really sorry to everyone that we didn't get to your questions. 4th year vet student here. How do you balance the needs of the patient with the wants of the owner? Some owners get angry if you ask them to come back again, as they prefer to have everything done in one visit.
Yeah. Yes, it's a great question. And I can imagine, especially at a vet school, you're seeing clients that sometimes aren't local. They've come a long way and they've waited a long time to get an appointment and everything that goes into a vet school visit. I think it really comes down to the education of the client and getting them to understand that you always have the patient's best interest at heart, and that if their dog, and I've been in this situation because I would have clients come from different areas, and we would just have to explain that our philosophy, and actually once I became fear-free certified, it made it so much easier to say, I practice by fear-free principles and I'm a fear-free certified. And so my philosophy is that I'm not going to put a patient or your dog through something that I think is going to be causing them undue stress and anxiety when we have options to mitigate that. What my advice would be is to be as much as possible, if possible, giving clients that information ahead of time. So what we would do is, on our website, I should also preface that I actually am not in practice anymore. I feel like I still am because it was not very long ago, but in the practice I used to be at, we would tell these clients ahead of time what to expect. And that included what the exam would be like and our philosophy that we use stress-free handling and fear-free principles, so that they knew as much as possible coming into it that would be a possibility, that we're only going to do what's best for the animal at that point in time.
Yeah, I would echo that preparing them in advance is the best way, that this is a process.
Yeah.
We've observed that as well in fear-free with clients who don't really know what fear-free is. They're not there specifically because of fear-free, but as long as you tell them up front, they accept things better.
Yeah, I like your word of process. I think it is a process for many dogs.
Yeah, it is. I have greyhounds, so you know that getting an orthopedic exam on a terrified, shaking, drooling greyhound is not exactly, it's an education, let's just say, for everyone involved. So everyone, I'm so sorry, that's all we have time for. Thank you so much for being with us, Dr. Shaw. And thanks again to all of you for being here, for your great questions, and to Zoetis Pet Care for making this presentation possible.